In a general musculoskeletal exam, evaluation of the ankle and foot is perhaps the most challenging. This is because many patients have non-articular swelling of the ankles and feet that preclude identification and testing of individual structures. Many types of arthritis affect the feet and ankles. On history, involvement of the ankle and metatarsophalangeal joints may indicate rheumatoid arthritis. Involvement of the first MTP with painful episodes of swelling and erythema is known as podagra, a manifestation of gout. Spondyloarthropathies often produce Achilles tendinitis and plantar fasciitis. It is often difficult to distinguish articular from non-articular pain complaints in the ankle and foot. Assessing for swelling and pain on range of motion can help you localize the pain to the joints. The ankle joint is a hinge joint in which the tibia and fibula form a saddle over the talus. The tibia and the fibula extend distally, ending in the medial and lateral malleoli, which provide stability and prevent rotation at this joint. The subtalar joint is between the talus and the calcaneus. The metatarsals and phalanges comprise the forefoot. The metatarsophalangeal joints are about 2 centimeters proximal to the toe webs. On inspection, swelling of the true ankle joint is appreciated anteriorly, as the two usual depressions of the tibiotalar and subtalar joints disappear. Focal swelling in the midfoot can indicate arthritis of the tarsal joints. Swelling of the metatarsophalangeal joints obscures visualization of the extensor tendons of the toes. Look at the toes, evaluating for evidence of bony enlargement, especially at the first MTP. On palpation, begin with the Achilles tendon, evaluating for swelling or tenderness. Check for tenderness at the plantar fascia insertion on the medial heel, which can indicate plantar fasciitis. Then palpate the ankle joint with the foot in slight dorsiflexion. Palpate the medial and lateral sides of the joint with your thumbs. In large ankle effusions, you may feel the fluid move between your fingers. Just as in the MCP joints, you can screen for MTP joint pathology by squeezing the MTP joints together laterally. If there is tenderness, just as with the MCP joints, palpate each MTP joint with 4 fingers, 2 on the dorsal and 2 on the plantar surface. The tibiotalar joint has about 25 degrees of dorsiflexion and up to 50 degrees of plantar flexion. The subtalar joint allows about 30 degrees of inversion and 10 to 20 degrees of eversion. The first MTP joint can dorsiflex 70 to 90 degrees and plantar flex 35 to 50 degrees. The other MTPs have about 40 degrees of both dorsi and plantar flexion, along with a small amount of abduction and adduction. Feel each toe to assess for fixed deformities. The PIP and DIP joints of the toes are hinge joints which do not normally hyperextend. The PIPs usually plantar flex about 50 degrees. The DIPs dorsiflex up to 30 degrees and plantar flex up to 50 degrees.